the screen? Okay. So along with the presentation, there's going to be a theme that runs through it. And hopefully it'll be apparent as we go forward. Just one thing that we always mention in giving these presentations is that this information sometimes is difficult and challenging and heavy. And if you're experiencing or feeling anything that makes you uncomfortable, please go to a spot. This is where I go mentally, and you can turn down your screen or step aside for a little bit. But this is our outline for the talk today. And what we want to hopefully have you or get across to you is what is medical neglect and how does it fit into the larger picture of child maltreatment? And how do you identify medical neglect and how do we contextualize it? How do we put it in its proper context in terms of the family, in terms of what's going on with the child, and put it in its proper perspective so that we can, if we want to, if things it rises to the level of making a report to DCF or to continue to monitor, how do we put it in its context? And then more practically, how do we make a case for medical neglect? And when is the right time to make a report? Oftentimes we think that, it's medical neglect and we think, well, maybe we should wait a little bit longer until it becomes more apparent. And it's very challenging sometimes to know when to make that report. It's unlike other forms of maltreatment where we see a broken bone and we say, this is abuse or this is concerning for abuse, then we make a report. Medical neglect isn't so cut and dry often. And then, the nuts and bolts of how to make a report to medical neglect. Okay. So just so you have a perspective on how encompassing this is for us, we get consults from across the board here in the hospital and outside the hospital on different cases of concerns for medical neglect, from ophthalmology, where a child might be at risk for vision loss, a child on the oncology service who parents might not be adhering to the post-chemotherapy regimen. The endocrinology we get quite frequently, and we have a case of that where someone a family wants to try alternative therapies for type 1 diabetes. A very common diagnosis of failure to thrive that we see often here in the hospital, where there's concern that the parents aren't maybe providing enough nutrition to the child. And then a very complicated cases of adolescent medicine where there's a child with anorexia, and what the level of concern is and when it reaches a level for medical neglect. So we're going to start with a poll, a question that you may have seen before, but just to get us oriented around the idea of medical neglect. So I think we're going to pull up the poll. Okay. So the questions are, what factors are considered necessary for diagnosis of medical neglect? And we'll give you 20 seconds. Great. So the majority of folks reported B and D. Answer. And that's correct. So while there's a lot of things that make us concerned and might make us think about medical neglect, there are a lot of things that do not meet the criteria for medical neglect, such as homelessness or a child coming into the hospital who's got poor hygiene. Maybe their fingernails are caked with mud and they haven't had a shower for a long time, or they have a diaper rash. These things are not necessarily enough to make a diagnosis of medical neglect. And so we're going to start off with a case that somewhat demonstrates this, hopefully. So this is a case of a 4-month-old who was sent in by their PCP, the primary care provider, to the emergency department after it was discovered that he was only 30 grams over his birth weight after 4 months. He was born an average weight of 6 pounds, 3 ounces. He lives at home with his parents, 2 half-sisters, an older brother, as well as several pets. Mom is the primary caretaker, and Scully does not attend daycare. So this is a child 4 months old who's 30 grams above birth weight. And just for perspective, a child gains between 20 and 30 grams per day in the first few months of life. So this is we're going to show you a growth chart, which is, if you're not familiar with this is how we track the progress of children along these curves. And this is at birth, and this is at 4 months of age. So well below the 3rd percentile. This would be the 50th percentile. And he's well below the growth chart, which would raise eyebrows for any pediatrician. The next slide is a picture, which just to brace yourself, is a child who's looks skinny, to say the least. And we take these photos at different angles and in different views to show just how skinny they are. So many children at this age would have much fuller appearance in their face, their arms, their buttocks, and so forth. So here's a second poll. Knowing the information that you have, would you make a DCF report? Yes, no, or maybe? Okay, let's see what people said. So good. So I appreciate that there is no clear, consistent answer here. It looks like the majority said maybe, which is exactly, and 41% said yes. I think this is exactly, you probably are grappling with some of the challenges and maybe not having enough information, and I appreciate that. So let me just go through some definitions here and ask you to think about what makes you uncomfortable about this case. Why are these cases so challenging? And more specifically, if you decided, if you have concern, what can you be specific about the worries that you have both in the short term and the long term for this child? Because when we get further down in the talk, we're going to try to figure out when and if we make a report, how can we relay those concerns to DCF so that we make a good report or an effective report? And how would you monitor your concerns about neglect and or the parents' compliance with recommendations once you establish your concern? And then the last question I always want you to ask yourselves is, have you, the collective you, whether it's the institution, whether it's your practice, have you exhausted your resources for helping this family? Is there more that we can do? So just a little background. We here at the Child Safe Clinic, we deal with all types of maltreatment, but far and away the biggest form of maltreatment that we see and that we get questions about and that nationally is most prevalent is neglect. And you might ask yourself, why is that? Why is neglect so much more prevalent or more reported than other types of maltreatment? Well, we know, for instance, sexual abuse is probably underreported, so that is probably a low number. But why is neglect so much higher? Well, probably because it is such a somewhat challenging case to make, that and there's so many people that are worried about these cases. So, you know, a child gets into a pill of their parents and lands in the hospital. Is that neglect? And so these get reported very often to Child Protective Services, and it creates it makes it very complicated, and it also inflates the numbers some. So the question that we have to ask ourselves, and what we'll try to get to at the towards the hopefully you'll have the answer to at the end of this talk, or a better feel for it, is what constitutes neglect? What is it that rises to the level of medical neglect? And how and do your personal values influence your definition of neglect? So is it just, you know, your perception of how the child is being cared for, or is there a standard by which we use to make a report? So the definition of medical neglect, or one definition of medical neglect, is a type of maltreatment caused by the failure of the caregiver to provide for appropriate health care of the child, although financially able to do so, or offered financial or other resources to do so. So at this level, it really is a question of appropriate health, and are the parents or the caregivers able to do what is being asked of the caregivers financially, in this case. There's other forms of neglect I just want to mention. There's educational neglect, emotional neglect, supervisory neglect. These also sometimes bleed into medical neglect, or we think we're diagnosing or reporting medical neglect, when in fact it's really one of these other forms of neglect that we should be thinking about. The AAP has pretty a good clinical report on the definitions and making a case for medical neglect. And in this report, they outline these 5 criteria for setting a standard for medical neglect. And that's the first one: is the child harmed or at risk of harm because of a lack of health care? So is there a lack of health care that's causing harm or risk of harm to the child? Is the recommended health care, does the recommended health care offer significant net benefit to the child? And again, the key word being significant. And does the anticipated benefit of the treatment is significantly greater than its harm or morbidity, so that reasonable caregivers would choose treatment over non-treatment? And I italicize these words because I think there's a lot of leeway or a lot of ambiguity in some of these words, and leaves us to have to parse them out a little bit and to try to figure out what they actually mean. And can it be demonstrated that access to healthcare is available and not used? So there has to be access. So if a family, for instance, doesn't have the means to get to that healthcare, or doesn't have insurance, is that might be a factor. And then this is a really important one when we think about families from other cultures, or from speak a different language. Can the caregiver understand the medical advice given? Okay, so these are basic criteria by which we use and think about when we're confronted with a concern for medical neglect.
And as you can probably imagine, when you're thinking about all of those different components that make up the definition, there's just as many components that could be contributing to why a patient or parent might not be following through on the recommended level of care to the expectation of the medical provider. So we're just going to take a second to kind of look at what some of those factors are. The caregiver's belief system. So some people do not prioritize medical care just as a family value or belief system, and it can be a larger value or belief system, which we'll touch on a little bit later as well. child's attitudes and behaviors may be a factor, especially when you have a child with a chronic illness that requires daily medication, sometimes multiple times a day. The level of cooperation from a child might heavily impact a parent's ability to follow through on the recommendations. We see this again a lot of times with kids with type 1 diabetes as they enter adolescence, where they're really trying to fit in with other kids and not wanting to attend to something that's going to make them stand out in any way. James touched on lack of access to care, so that can be a bunch of different things that influence access. So do they have insurance? Do they have transportation? Do they have somebody to watch their other kids so that they don't have to come to a 3-hour appointment with 4 kids in tow? So all the different components of access. Poverty and economic hardship can go hand in hand with access. Family chaos. So just when you have other chaotic things going on, whether that's just the sheer number of people or the inability to take time off of work to go to a doctor's appointment, not having other extended family or natural supports to help manage an illness, can all be a factor in adherence to recommended guidelines. Lack of awareness, knowledge, or skills. So sometimes that can be a language barrier, but can also be a lack of understanding about why a kid who looks okay right now, but has a chronic illness needs to follow a specific regimen because the parent just may not understand the long-term impacts in the same way that medical providers do. And then lack of trust in healthcare professionals can be a factor as well. And we see this sometimes in a unique way in our state because there are only a limited number of specialists. So if you started off with a specialist in GI, for example, and you didn't really get along with that doctor, as a parent, you don't have a ton of other choices. You would still need to stick with our healthcare system for the most part, or venture out of state to find a similar specialist. And so a lack of trust in the healthcare profession can really impact somebody's ability to follow through in a rural state like ours. And it's not all on the parents or providers or patient. There are a number of healthcare provider factors that can influence a family's adherence to recommendations as well. So sometimes there's a disconnect between what parents are understanding and what healthcare providers think they're understanding. So really getting to know what level of health literacy patients and parents have can go a long way. There can also be a lack of communication in the medical setting. So you may have a specialist or a few specialists seeing a child, and the communication with the primary care office might not be going as well, or there might be a home visitor in place and they're not necessarily up to speed on what the primary care office is concerned about. So those things can either amplify or diminish the level of concern for healthcare providers. And then the one on the top and the bottom kind of go together. So healthcare providers could have a misconception that medical neglect is accepted in that family's value system or cultural system, or healthcare providers can have a pretty poor understanding about cultural beliefs or practices of the family that are outside of ones that they've already been exposed to. And anytime that there's a poor understanding or misconception about why a parent is doing something, it's going to lead to less adherence with the recommendations. And as we've pointed out already, a number of times, it's not exactly clear cut, this medical neglect definition. So it's a pretty fine line between parental autonomy and child safety issues that would warrant government intervention in a family's life by calling Child Protective Services. As a team, we used to refer to reporting as not being a benign decision, but actually as we attend more trainings and learn more about the recent research that's being done in the field of child welfare, there's a lot of data that shows, especially regarding neglect, and particularly with families of color, child protective intervention can actually be more harmful than helpful. So something to be cognizant of when we're trying to determine if our level of concern raises to medical neglect. And then if it does, is it something that then raises to the level of reporting to child protection? It doesn't mean that we don't report. It just means it's important to think about and examine our roles before we reach that point. And so these are just some examples of kind of common, controversial parental choices and or child safety concerns, depending on where you're coming from. So Vermont is not the most diverse state, as we all know, but even in Vermont, we are exposed to other cultural beliefs, other religious beliefs, and those can be very challenging in terms of thinking about whether or not something is medical neglect. So in case anyone's looking for some reading recommendations, here are a couple of books that address this exact topic. The Spirit Catches You and You Fall Down chronicles the struggle of a Hmong refugee family from Laos, and their youngest child is diagnosed with a severe form of epilepsy, and it kind of chronicles the cultural conflict that obstructs her treatment. And then The Last Strawberry looks at the conflict between what Christian Scientology recommends in terms of an approach to medical care and what we would most all be used to in terms of medical care in this country, and the drastic difference between those that ultimately led to this mother's child dying, and her reflections on that. So just interesting ways to expose ourselves to some of those other cultures and religions that impact how people make decisions about medical care. So as a group of mandated reporters, you're probably all familiar with the fact that DCF is not just operating on their own whims and fancies, but just to point out what the actual statute says in our state around neglect: failure to supply a child with adequate food, clothing, shelter, or health care. And in this definition, adequate healthcare includes any medical or non-medical remedial healthcare permitted or authorized under state law. It then goes into a little bit around religious beliefs, which is certainly not clear cut. There is a religious exemption in our state, but it's also written in a way that says, even if a parent or caretaker is making a decision based on religious beliefs, it doesn't automatically mean that it's not neglectful. So there are other things that need to be taken into context. And just to continue to put things in perspective, so that last slide was the statute or the law around what the definition of neglect is. Then Vermont DCF, as with all child protective agencies, have their own policies that they follow. And then additionally, they have practice. So while there are overlap between these three buckets, there are differences as well. Not everything that is in policy or practice guidance is specifically outlined in statute, which means as much as we try to have consistent approaches, same thing with the healthcare field, we try to be consistent about how we approach these concerns. There's practice guidance, and so there are going to be differences, and you may interact with a concern with DCF for a concern about medical neglect in one situation and have a different experience in a different situation, even though both of them are related to neglect.
So we're going to pause here for just a quick second. If you have questions, you can type them in or we can address them at the end. But you're probably wondering, was the case previously concerning for medical neglect? And I think how I would just reframe that is, when we looked at that case, while it was somewhat horrific in that the child had not gained very much weight at all since birth, 4 months. We took a larger look at it and looked at it in the context of the family and what the family was experiencing. And in and of itself, first of all, you have to make sure that there's no medical component to what's going on, which takes some time. Then you have to unpeel the layers of what is going on with in the household and so forth. And then, then you have to decide, is it medical neglect / starvation, intentional starvation, or something else? And this is what makes it complicated. So there's one question: at what point should a provider report missed well child visits? That's a great question, and I think we're going to get to that come in a little bit when we try to determine what the actual harm is to the child by those missed appointments, or what is the harm to the child from not following medical recommendations. And this is the challenge when care providers make that determination that it rises to the level of medical neglect and a report, and how do we translate that concern into an actual effective report? So we're going to get there. So here's the next poll, which I'll leave up for a few seconds. And when reporting concerns of medical neglect, the information that is important to convey is okay. Let's see. Perfect. 100%. Well, I think that speaks to your understanding of the importance of translating that concern into harm. And I think we're gonna see that in the next cases as we go. So here's the second case that we wanted to present to you. It's of an 18-month-old who goes to the ED after her older siblings, 4 and 6 years of age, told their parents she was acting sleepy and they couldn't wake her up. When the child arrived to the emergency department, the parents are worried that Elena may have had a seizure. A urine toxicology screen was performed and the tox screen comes back positive for THC. Elena's parents say that the only marijuana in the house is in a secure jar in their bedroom and that Elena doesn't have access to it. They tell providers that there are no THC edibles in the house and the exposure to secondhand smoke is the only explanation they can think of that would cause a positive UA. Okay. And this is, lest you think this is, fictionalized or very made up, we are seeing a lot more, as you can imagine, THC ingestions here at the hospital, given that THC products are becoming much more common and available here in Vermont. So here's the next poll. Would you make a DCF report or not? Okay. Wow. Great. So again, it shows that there is a majority of folks said yes, and some people said maybe, and some people said no. And I think that, again, without more context, sometimes these are not cut and dry. In fact, most of the time they are not cut and dry. And I appreciate that there is people who are a little bit cautious in saying that they might make a report or not. So here are some of the questions that we ask ourselves. Was it neglect that led to Elena's ingestion? Was it neglectful? Would it make a difference if the parents waited 3 hours to bring her to medical care, as opposed to bringing her in right away when they realized she was sleepy? And what about if they waited until symptoms got worse, when she was maybe, not waking up at all? Would your level of concern be different if it was another substance like Suboxone, or grandpa's blood pressure medication, or maybe fentanyl? And again, I know we're going to harp on this, but have you exhausted your resources for helping this family? Have we collectively done what we can to help this family?
So when our team thinks about ingestions, we wrote some guidelines around how we think about them and how we would like other medical providers to try to think about them as well. We want to think about, what did the child ingest? So in this case, for example, THC is a product you can have in your house the same way that people can have alcohol or drain cleaner. So the item in and of itself doesn't necessarily mean that there is neglect going on. We want people to kind of check their bias or their personal values around that. It comes up quite often when kids ingest Suboxone or methadone, that the immediate response from a provider might be, this is definitely neglectful. However, those items can be prescribed to parents, and we all know that we have items you can buy in the cleaning aisle that can cause just as much, if not more, harm than prescription medication. So just kind of starting with, what did the child ingest and what's the context around how they got access? So that could be like, is it stored in a place where the child easily has access to it? But it can also be like, were parents under the influence, and as a result, the kids were able to get access to something that they don't normally have access to, which kind of ties in hand with considering supervision. So given the age of a child, supervision levels tend to, or the expectation for supervision levels tend to go down as children get older. And in this example, there were several different aged kids. So without knowing exactly how long the 4 and 6-year-old were alone with their sister, it's hard to say if supervision was a factor. We also want to take into consideration a parent's explanation. So I would say the most common explanation that I've encountered, and I do follow all of the accidental ingestions that get seen at UVM, the most common one is that a parent knew that they dropped something and were unable to tell whether or not their child actually ingested it, but they couldn't locate it. So they decided to access medical care as a preventative measure, which is a much different context than I couldn't wake my child up in the morning. I have no idea what happened and I had to call 911. And then we like to talk about delay a little bit, because delay is not just about time that has passed. So from the time that a parent may become aware that their child could have ingested something, there's a lot of other steps that might happen before they present to an emergency department, for example. So a parent may call their PCP first. They often call poison control first. And sometimes the recommendation from poison control is to wait a certain amount of time and observe for different symptoms before accessing care. So just because a child may have had a possible ingestion 3 hours before they presented to the ED doesn't mean that there was necessarily medical neglect in terms of delay in care. And then we kind of think of ingestions in 3 buckets. So intentional poisoning, some examples that come up would be putting Benadryl in a baby bottle, using CBD or THC gummies as a sleep aid, or blowing pot smoke into a young child's mouth. Accidental ingestions, this is where I would say the majority of these fall, where a medication of any type or a household toxin of any type gets dropped on the floor or left out or more accessible. Parents are aware it happened and they seek medical care, including contacting poison control in a timely manner, but the child something still happened and the child does need at least monitoring from the medical world. And then the last one, negligence resulting in ingestion. So those are typically happening when a parent is under the influence, and then as a result, the child is able to ingest something that's in their environment. As we've kind of alluded to, especially in the category of neglect, bias can play a huge role in how we're thinking about the situation in front of us. I have some examples on here of a couple of different common types of bias. So implicit bias, those are our attitudes and stereotypes that we hold without our conscious thought about them. And research shows that most of our action occurs without conscious thought, which allows us to function, but also when you think about that, can really influence how we're interacting with parents and families that we're working with. So an implicit bias related to neglect could be teen parents don't really know what their kids need. So of course they're neglecting them, they just don't know. And you may not be aware that you even hold these implicit bias until somebody else calls you on it, because it's just something that you innately believe. Availability bias is the tendency to accept an explanation based on your past experience with a similar situation. So that concept, I know Xander's mom won't take him to get his ears checked. She never brings him to the primary care when suggested. So just because your past experience with this mom is that she has not brought him to the pediatrician when recommended, you've already come to the conclusion that that won't happen again this time, despite the fact that maybe you're a school nurse and you're recommending it again. And then confirmation bias can be pretty similar to availability bias, but instead of basing it on your past experience, you're actually you've already reached the conclusion and you're seeking out the information to support your conclusion. So you've already decided that Layla's family is neglectful, and then you can say there's so much neglect going on there. Layla's at school without her inhaler again. So you're only seeking out the facts that support the decision you've already reached. So that can be a bit of a bummer to think about, especially when we know that bias plays a role both in who we report to child welfare as well as how we interface as a healthcare system with families. So what can we do about that? It's important to seek out objective information from all sources. We'll talk a little bit about how provider meetings and consults with our team can kind of help check some of those beliefs that we may have developed about families before raising to the level of DCF report. Working with a multidisciplinary team to make sure that you understand all of the components that are impacting a family's action and decision making. And formal and informal reflection on how you're doing the work, including peer review, and being open to your peers and colleagues talking to you about how your own bias might play a factor, being open to offering that feedback to them as well. So knowing implicit bias exists, slowing down, thinking about what your concern is and how you can be really clear that your concern is not based in your bias about the situation, and then consulting with others when needed, whether that's your team within the setting that you normally work in, or when needed, bringing in a larger team to talk about concerns.
So we're going to pause here for a quick second, but I really want to stress the importance of slowing down, especially in medical neglect. If we're thinking about making a report, I think it's incumbent upon us to slow down, step back, and make sure we have all the information available to us. And I realize I always say that I can't go out and get all the information that DCF can get or other people can get. But to the degree that we have the information or we can get the information that we need to make sure that we're making the right call, I think it's incumbent upon us to take those steps before we pick up the phone and make a report. Okay. The next case, or the next question is, parents who choose to deviate from recommended immunizations or treatment due to religious beliefs would warrant a report to DCF. True or false? Okay. Great. I think that's I'm glad you all recognize that. And we'll go forward. So religious beliefs, immunizations in general, 1 second. We're going to get to the next question in a minute. Let me just close that. So immunizations in and of themselves, whether a parent chooses or not, is not necessarily reportable. So this next case is alternative medicine for diabetes. We're not trying to get you lost in the weeds on this. And the main point is that the parent is trying to wants to try an alternative medicine for type 1 diabetes. So the case in brief is the child was diagnosed with diabetes type 1 at 7.5 years of age. And type 1 diabetes, just so we all know, is somewhat of a genetic disorder where your pancreas is not working well. It's unlike type 2 diabetes, where there are a lot of other factors that can contribute to it that you can mitigate that might be able to prevent you from having to take medications. Right off the bat, the diabetes team was concerned about the mother's understanding and coping with type 1 diabetes, specifically in that mom was wanting to use homeopathic or natural treatment for diabetes and not using the standard treatment of insulin. And she was pretty firm that she didn't want the diagnosis to be made public to her classmates and for fear that the child would be bullied. At 1.5 years after the diagnosis, so at around 9 years of age, she started this virtual treatment regimen from an international diabetes expert, which was very different from what the endocrinology team was suggesting. So no short-acting insulin to cover her meals. Meanwhile, the child was losing weight or not gaining weight, and her hemoglobin A1C, a marker of diabetes control, was rising and showing that she wasn't at control at all. And we can tell that mom has a very different perspective of how the treatment is going than what the actual numbers show. So this is her hemoglobin A1C. You can see that the target is 7.5, and she was continuing to escalate over time. And her growth charts, as we look at them, they show that she was losing weight at 9 years of age, or at 8, between 7.5 to 9 years of age, she was losing weight. So here's the poll. Would you make a DCF report at this time or not? We'll pull up the poll. Okay. Okay. Great. So again, not clear cut. So this is we'll figure out what the theme is here. So what are some of the questions that we ask? Again, trying to drill down on what are the specific risks. We're all concerned about this child, by all means. The endocrinology team is, the primary care provider is, the school is, but what are the specific risks, both short and long-term, to the child? And at what point, if any, does DCF intervention seem appropriate? And how do you monitor your concerns about the neglect And how long do you monitor this before or after you make a DCF report? And again, have you exhausted resources for helping this family? Have you come to the end of what we can do as an institution before making a report? So this is what we ask you to think about, is how do you translate your concerns into a meaningful report? And when we decide to pick up the phone, this is what we should all be ready to provide or think about, at least. So this is an example of some of the risks, or how we break it down. So the risks or the concerns, for instance, the weight loss or the persistently elevated hemoglobin A1C. And then we think about, okay, in the short term, why is that concerning to us? Well, we know that a child who is not well controlled with type 1 diabetes can go into diabetic ketoacidosis, land in the hospital, land in the PICU, get some cerebral edema, and it's not hyperbolic or it's not overstated that the child could die. Long term, the child can get things that occur from having a persistently elevated hemoglobin A1C or poorly controlled diabetes, retinopathy, so problems with the eye, problems with the nerves, heart disease, depression. All of these things can be affected by poor control of the diabetes. And then to go beyond that is, let's make a recommendation. What is the recommendation that we want DCF, or that the parent is not adhering to? And so we would say that she should start taking the insulin per the recommended guidelines, and with close follow-up with the endocrinologist. And similarly, we would do the same thing with weight loss and stigmatizing. And all of our concerns, we would outline in this manner to try to make it more tangible for to make a report, an effective report.
And Pete, this should address your question a little bit. In thinking about all these different components and all of the factors that play into how parents make medical decisions, when is the right time to make a report? So have you fully understood the reasons why compliance or adherence isn't going on right now? So not just like what you suspect, but really had a direct conversation with the parents to try to understand their perspective as to why they either haven't been able to follow through or don't want to follow through. So families' views of the recommended medical care as well. Ensuring that all of the medical communication has happened via an interpreter if English is not the family's first language. Have you made any attempts to increase social support for the family? So, I use diabetes as an example a lot just because it requires around the clock effort from parents, especially in the beginning of that diagnosis. So have you had a conversation with mom about whether there's an aunt or grandma who might be able to help give them a break from being constantly in charge of the management? Who else in the family is involved in caretaking, and have you invited them into the office to talk about the recommendations and the concerns that you have? Sometimes people don't have a lot of natural supports, and so have you explored if there's community resources that might be able to offer some of those things? While they typically aren't as extensive as natural supports can be, it could offer some type of assistance either in ongoing understanding of the medical recommendations or ongoing management of care. Have you worked on a coordinated response? So have you brought in, if you're the social worker in a primary care office, have you brought in the doctor to share like what your concerns have been? Or if you're the specialty physician, have you reached out to the primary care office to see if you are having a similar experience or share those concerns, or whether a different provider has found a more effective way to work with that family? And then a strong medical home. So having a primary care office where there are care coordinators and other providers who are able to kind of wrap around the services that families need in order to be able to follow through. So in thinking specifically, somebody asked about reporting missed well child visits. So have you addressed all of these factors that might increase attendance? And then also, have you identified what harm could come to a child from missing well child visits? And just having worked at DCF a pretty long time, if a kid doesn't have an ongoing diagnosis that would require medical care on a regular basis, they are unlikely to get involved just in missed well child appointments. So really working on what you have to offer as a provider in terms of increasing somebody's buy-in is probably a better place to put your energy if a child doesn't have a chronic illness. We touch a little bit on how to make a good report to DCF in terms of medical neglect concerns. This is just some of the things that people experience when they have to make reports. It can be really time consuming. It can be stressful. You can be worried about the impact on the relationship with the family, but we know that in some cases it's necessary. So some of the basics, probably most people on this have made reports before, but being as prepared as possible with family demographics. A lot of times kids live in more than one household setting. And so trying to get as much information about where children spend their time, especially when, if you're concerned that the medical neglect is like a medication related issue, gathering as much information about all of the settings that a child lives in is going to be helpful to demonstrate where your concern is. So that leads nicely into being really clear about your specific allegation. So again, meeting as a team ahead of time to kind of enumerate what your short-term concerns are, what your long-term concerns are. And a lot of times for medical neglect cases, we'll also recommend to teams that, or remind teams that the people at DCF who are reading your reports and responding to families are working in the social work field. And so they may not have very much information about cystic fibrosis unless they've already had one case in their career that dealt with that, or diabetes, or whatever the medical condition is. So as specific as healthcare providers can be about the condition, the medical recommendations, the standard of care, and then what is not happening, as well as what has been offered to try to help support the family in order to make it happen, and the long and short and long-term harms as a result of that lack of adherence. It's helpful to add additional risk factors if you're aware of them. For example, if this is a family that blows up at each other during every visit to the healthcare office, it would be helpful information to share that. But you really want to spend the majority of your prep time once you've decided to make a report to make sure that you're being super clear about what the medical condition is that the child has, what the recommended medical care is from this provider, and then what harm could come to the child as a result of not following that recommendation.
So just to finish, when we make a case for medical neglect, we speak honestly with the family. We are transparent as possible. We document clearly all the conversations and concerns that we have. We discuss the concerns with our team, and we try to reach out broadly. And we enumerate the harms, both short and long term, and consider alternatives to reporting. I think we're going to close there. And thank you all. And we'd be happy, although it's 1 minute until 1 o'clock, to answer any questions that you might have. And if you want to chat in with what